Get us started. We are recording. Thank you so much, Lindsay. Let me press it on my side. We will be recording and adding this to our PFCC Partners YouTube channel. The live script will also be available. PFCC Partners, we are located, our home office is in Long Beach, California. And you can see on the screen what we're all about centering the inclusive human experience of health, wanting to reinvent through radical collaboration and be a catalyst for system transformation. Basically just saying, wanting to make sure that people are involved in their care and have seats at the table. So we know that the healthcare system is very complex. There are a lot of people, hundreds of agencies and organizations that make it up, trillions of dollars that can make it difficult for people to access the care that aligns with their needs, health priorities, and preferences. So here at PFCC Partners, we believe in a system that centers the care and care processes for the person to reduce that complexity and advance. I'm going to ask if somebody could mute for me, please, to be able to advance culturally humble, equitable healthcare systems. So with us at PFCC Partners, we recognize the need to have open space for patients, family caregivers, and community voices to drive those improvements for these complex systems. We know that these voices are a huge catalyst for improvements and the system's change. Our team has decades of passionate experiences partnering with healthcare systems and leaders engaging with those with lived experiences in the efforts to improve healthcare. PFCC Partner works to open space, creating partnerships that allow for this improvement. One of the ways, the main way that we do this, I shouldn't say the main way. One of the ways that we do this is through the PFA network. This network helps to fill the space. And it's a network, it's a community made up of patients for patients, being able to use their lived experiences, being able to connect with one another, sharing various opportunities that are available, increasing knowledge, as well as doing skills development. So that's just a little bit about PFCC Partners if we are new to you. Without further ado, I want to introduce our presenters for today with the topic of building strong coalitions, Unlock 2.0. We have Dr. Jose Delgado, who is a Los Angeles native, who provides executive leadership at In Community, which is Georgia's largest provider of disability services. He is the Chief Operating Officer. In his spare time, Dr. Delgado spoils his rescue pit bull, Adrian, gravitates towards live music, advocates against healthcare inequities, and is an avid international surfer. Ooh, I'd love to know where you've been. And then also presenting with Dr. Delgado is Rita Young, who is currently the Director of Grassroots Engagement for Unlock 2.0. I'm going to ask if everybody could mute, please. In her previous work, Rita was a corporate trainer, public policy director, and coalition builder for several nonprofit organizations that support individuals with developmental disabilities. Rita Young is the parent of 2 autistic sons, has been a freelance consultant for the past 9 years, and has worked with a variety of clients, including state agencies, nonprofits, and individuals. Without further ado, I'm going to stop sharing and pass it over to Rita.
Thank you so much, Naomi. I'm going to share my screen. And then we can go ahead and get started.
And as Rita loads up her screen, a couple of formalities or maybe informalities. no need to call me Dr. Delgado. Let's just go with Jose. Chances are I may not take your insurance anyways. This is a very fluid and natural conversation. So I hope as friends and as colleagues, you guys feel free to ask as many questions as you can. I'll be looking at the chat as Rita's navigating the PowerPoint slide, but we'll be going back and forth in a conversational manner as we navigate this presentation today. And again, thank you all for joining.
Okay, can everyone see the presentation? Okay, great, wonderful. All right, so you heard a little bit about Jose and myself. Jose, anything else you want to tell folks? Although your introduction was so exciting, I just feel so inadequate. I'm not an international surfer.
Never that. Truth be told, I'm a big nerd, and Rita's actually the cool one of the group. So you guys will learn that shortly.
All right. So we're going to go ahead and move forward. We're going to talk a little bit about our coalition building activities. And one of the things to let you all know that we have migrated our name just recently. So we are, instead of Unlock 2.0, which we were last year and maybe a month or two ago, we decided to change to Unlock Georgia. So you might hear us referring to Unlock 2.0 as Unlock Georgia. So that is something brand new for us. So we are a home and community-based coalition. And our purpose is to monitor and respond to intellectual and developmental disability issues related to home and community-based services at the state and federal level. We're going to talk a little bit about home and community-based services in just a moment. But we're basically monitoring issues that can affect individuals with intellectual and developmental disabilities who live in Georgia. And we are tasked with increasing the presence of trained grassroots advocates at the state capitol and individuals who are engaged in in issues that are important to the coalition. And it goes without saying, we also are welcoming and inclusive of people and organizations that represent the broad base of the disability community. Anything you want to add to that, Jose?
No, but I do think it's important, especially for this group, to dive into what HCBS actually is. So for those of you guys who don't know, those fancy acronyms are home and community-based services. And HCBS essentially provides for supports and services beyond those typically covered by Medicaid, by the Medicaid program. And it enables people to remain in their community setting as opposed to being admitted to a long-term care facility, etc. So for us in community, that might look like a group home, it might look like a day program, it might look like job coaching and employability, helping somebody with a disability find space within the community.
So building a coalition can be, it's quite exciting and challenging at the same time. So what we did last September, we're a relatively new coalition. We just started last October of 2022. So last September, we invited some of our statewide organizations to have a conversation with us on their interest in building a coalition. And we were very, very fortunate that all of these organizations that are listed here, that are statewide organizations, I think there's one that maybe not statewide, but for the majority of the rest of them, they are agreed to participate. And we're very excited that we were building this HCBS, Home and Community-Based Coalition.
Yeah, let me also add, part of the brainchild for this piece as well is when me and Rita were examining kind of the landscape when it came to advocacy groups and provider organizations that were attached to the mission of serving people with disabilities, we realized there were quite a few groups, they were all scattered. And the idea behind building a broad-based coalition is to create a bigger microphone, bringing these groups together under one umbrella so that we might have strength through numbers when we're in our own respective political forums, coming together with similar ideas and thoughts and virtues that we can celebrate together and we can be consistent in with messaging, which is really, really powerful.
Absolutely. Thank you, Jose. So in terms of the coalition, one of the ways, not only do we engage statewide organizations, but even in our very first year, we wanted to engage the community as well. So starting a coalition, there's a lot of groundwork that goes on behind the scenes, in front of the scenes, and with organizations, with individuals. So in our first year, we offered trainings, a series of 5 lunch and learns, and we used the vehicle of this amazing movie called Crip Camp, and it's on Netflix. And Crip Camp offers a public use curriculum. And so we used that curriculum and offered it weekly to advocates and anyone else who was interested. And what we also did is we engaged our steering committee, the organizations that I just showed you a slide ago, to be instructors or facilitators actually of those conversations. So it was a great way for us to get to know each other and to provide this disability training to the community. It went really well. We also offered opportunities to give testimony at our Capitol during the legislative session. There were a couple of touch points with our Senate and House appropriations committees where they take public comment as a part of the budget process, and we were able to support several self-advocates. An individual, a young man actually with Down syndrome, provided testimony at both the Senate and the House appropriations committees, as well as several parents, and they provided testimony on behalf of the coalition. We also have social media. Facebook is very active, and also Instagram. We have a subscriber list that we send out news and information to. We're also building a new advocacy platform for year 2. It's called Voter Voice and Fiscal Note. So we have a new tool to engage advocates we're real excited about. And then also in year 1, we wanted to be sure that we, as a part of our activities, engage with underserved groups. And in year 1, the way that we did that is through our partnerships through the steering committee. So we partnered with Parent to Parent of Georgia to provide training to their Spanish-speaking advocates, as well as a group of advocates from East Africa. Anything to add to that, Jose?
I would just double down on the word community. So when we talk about advocacy, we're not just referring to the individuals that we serve, aka people with disabilities, but we're referring to their families, advocates, vendors, people in our space and healthcare arena at all levels. And I think that's really, really important. We haven't limited our audience, and we know who our stakeholders are. And I think many of you guys could probably share that community health programs and advocacy in this way improve access to preventative healthcare services. They engage citizens at every level. And truth be told, from a healthcare perspective, it also seeks out lower medical costs. So something to think about.
So Lisa's asking where our funding comes from. That is an excellent question. Our funding comes from the Georgia Council on Developmental Disabilities. They are our main funder, and the project is housed at In Community, and Jose is COO of In Community. So I hope that helps. And then Emily says, we have not, she asked if we have a relationship or have had a conversation with Kaiser. We have not. But if you have any ideas, Emily, we would absolutely love to talk with other potential partners. And Naomi, thank you. Yes, every state has a council on developmental disabilities. It's a part of the Developmental Disabilities Act, a federal act. So each state has a similar council. Thank you for bringing that up. So year 1 was very action-packed. The intent was to build the infrastructure of a coalition, but our environment, our legislative environment, and just political environment in general had other plans for us. And so we were extremely busy doing 2 things at the same time, trying to build an infrastructure for a coalition and also responding to the environment that presented itself to us. So coincidentally, we started last August, and then last August and September, there was a a Georgia State committee specifically geared towards hearing issues developmental disabilities. So there's a group of senators that started an IDD Senate study committee, and they went across the state to several locations asking stakeholders to provide public to going to those study committee meetings. Then secondly, here in Georgia, we are state agency that provides leadership for developmental disability issues and funding. They contracted out for a comprehensive rate study of all of the services regarding developmental disabilities. And so that was something that we also reacted to and provided comment to our state agency. It's called the Department of Behavioral Health and Developmental Disabilities. Shortly after that, a month later, we are into the legislative session, which here in Georgia is from January until typically the end of March. And so Jose and I were meeting with state leaders to talk about Unlock, to talk about the importance of higher wages for our direct support staff, which we'll get to in a moment, and more investment in home and community-based services. So that takes us through till about May. And so this rate study was moving along because, as you know, these things it's not like an on and off switch. They have to go through several different state agencies, our Centers for Medicaid and Medicare, CMS. So it's quite a lengthy process. We thought that this rate study was moving forward, and our governor, May the 10th, I believe it was, put a halt to that. And it's called a budget disregard. And so put a stop to that, along with many other disregards. But we are focused on IDD, our IDD rate study. So we also recently, in the last month and a half, responded to that as well within the coalition.
Yeah, I think we did something really special here too. Again, being a broad-based coalition, it allows our members to not just come from one facet of this healthcare process. And so when you have family members, you have parents, you have a physician, you have an advocacy director, all coming into these similar shared spaces as congressional members of the Georgia State Congress, I think it hits differently. The stories feel different. They feel more personal as compared to a lobbyist. And I think we really made a lot of great movement. It also just shows so much support for the people that we're trying to serve. And so again, you really only get that from being as inclusive as we were organizing this broad-based coalition piece.
Jose talked about home and community-based services. If you need to hear that again, I know that sometimes I need to hear things multiple times. And so we're trying to make it sort of as plain as we possibly can without talking about with too many acronyms, et cetera. As Jose mentioned, HCBS services are services that are provided to individuals with disabilities. We focus on the IDD side, but most certainly they are provided to individuals with physical disabilities and individuals who have disabilities and are elderly as well, that allow them, support them to stay in their homes and their communities instead of institutional settings. So some examples, and here's where some of the jargon comes in. In Georgia, we have community living supports, which can help someone, again, provide service in the home, community access, to take someone out into the community and to support them to do that, community access group, in more of a group setting. So that could be a day program or something along those lines. Community residential alternative, which could be what we would traditionally think of as group homes and respite. So those are some examples of HCBS services. We're going to talk a little bit about waivers. This is a topic that is national in nature as well. What is a Medicaid waiver? It's called different by different names in different states, but overall that Medicaid waiver is the general term. It's a funding mechanism for individuals with intellectual and developmental disabilities to fund their services, to pay for services using Medicaid. In Georgia, as in other states, there are options. You can go the traditional provider route, which would be organizations and agencies like In Community that Jose provides leadership to, or you can go participant direct. And as a family, you can train and hire, recruit your own staff, and then a third party actually pays for those services. That's what I do with my two sons and have been doing that for a number of years. So we do have choice. We have a 7,000 person waiting list here in Georgia for our version of Medicaid waivers, which is called the New Options Waiver Now or the Comprehensive Waiver. And those are two different waivers that we have, and the funding is slightly different for both of those. But there's about 7,000 people waiting for services. I know that I was watching the states that you all are watching this presentation from, and probably some of you have waiting lists and some of you may not have a waiting list depending on the state that you're coming from. We're very pleased that there were 513 new waivers added in the last fiscal year. And then this year, the year that we were working on, 2023, we were able for 500 new waivers, and those started July 1st. And that's about $9 million in state funding.
Yeah, and just to be clear, this is really where our advocacy efforts were spawned from. We have people with disabilities, with official diagnosed disabilities, who do not have access yet qualify for access to care. It's a travesty. It's tough to hear about. We hate that there is a waiting list. You might hear this as a planning list as well, but we're going to default to waiting list. And it can take years before you actually get a waiver. So a lot of people end up jumping on this list well before they're even qualified to take advantage of these services after they become an adult. So it's a tough thing to deal with. It's not just a Georgia thing, it's a national problem, but Georgia certainly is low on the list.
And just on a personal note, my sons have had waivers for a number of years. It was truly a fluke that both of them received waivers at the same time. I just literally happened to be in the right place at the right time. But families often linger on those lists, as Jose said, for many, many years, don't hear anything back from the state. And so I always encourage families to be as persistent, be polite and persistent, and follow up and keep following up so that folks know that you are watching and waiting for those services and needing those services. Direct support professional wages are wage and workforce, the workforce shortage here in Georgia. So in our state, we have an average, and I believe this is, well, I don't believe, I know this is national. And Jose, I know that you are connected with a national organization, so please chime in. But here in our state, it's about 46%, could be a little bit higher, of staff turnover rates. And direct support professional is that individual that works one-on-one or 1 to 2 to 3 and provides that in-home care, out in the community support for our individuals with intellectual and developmental disabilities. So they are paid very low, unfortunately. And as you can imagine, this hinders recruitment, retention, and the overall quality of services. Here in Georgia, the published rate is $10.70 an hour for direct support staff, although some agencies can pay more, and Jose will talk about that in a sec. we have not had a raise typically for our direct support professionals in about 10 years or so. With this new rate study, comprehensive study, which I feel certain that during COVID, probably other states did something similar. The new hourly rate will be $16.70. And we're very hopeful that this will pass. And at the same time, we will continue to do advocacy around this issue.
Yeah, and again, just to reiterate, a direct support professional is often known as a sort of caregiver in most other medical communities. And they work directly with our people who have intellectual and developmental disabilities. Their aim being to assist people in realizing their full potential. They help people become integrated and engaged in their community. This might look like helping them with personal care tasks, including assistance with personal hygiene, grooming, feeding, being ambulatory, medical monitoring, healthcare related tasks, but also being a friend and a therapist. I mean, these are multifaceted jobs, and somebody at Starbucks or Whole Foods is likely getting paid much more. This is a national problem. The White House has addressed this problem in recent dialogue in the last few weeks. That's how well known this problem is. But we still have a long ways to go. And until we can afford to pay this healthcare staff reasonable wages, we're going to continue to see that recruitment and retention issue exist, which is tough because we already know there's this waiting list problem, right? So even if you do get off the waiting list, you do get a waiver, now we run into the obstacle of, is there actual healthcare available by providers considering they have these staffing issues?
And Jose, Lisa is saying, my son was on the list in Connecticut for 13 years before he got services. Wow. Okay. That's incredible. Yeah. Most definitely should not be happening. Also, there's something called Appendix K. Maybe you all have heard of that, or maybe you haven't, but during the public health emergency, CMS, the folks at the federal Medicaid and Medicare, provided certain flexibilities in waiver programs due to the public health emergency, and provided federal funding, extra federal funding to states, all states. And so some of the things that, some of the flexibilities were for agencies were able to provide and pay a higher rate to direct support professionals, but that is going away as of November 11th. However, we found out maybe a couple of weeks ago that CMS is offering states the ability to extend some of the flexibilities within that Appendix K. Another one that was very important to some family, or to quite a few families in Georgia, is a family caregiver option. Families, because of the workforce shortage, because of COVID, in Georgia, families were able to be either hired as caregivers for their sons and daughters that lived with them. And if they self-directed their services or participant directed their services, they could as well. That was a huge help and option for families. And so I know that families nationally are also looking for that to be extended as well. And then finally, ER admissions. And Jose I'm sure will chime in because this is his area of expertise. People with intellectual and developmental disabilities, I can't imagine this is only happening in Georgia, but are being abandoned in emergency rooms for non-medical reasons because there's a lack of staff to provide adequate care. Jose and I talked with an organization here in the Atlanta area that is looking at this issue, a group of about 11 hospital systems. And some of the stories that they gave us were just heart-wrenching. One of them that comes to mind is an aging caregiver had passed, and her adult son with Down syndrome was abandoned at the ER, and no one sort of knew what to do in that particular situation. And so cases like that is what we're hearing about.
This is part of my entryway into this fight as well. As a traditionally trained emergency medicine physician, I've worked in places like LA County USC Hospital, the largest kind of emergency department west of the Mississippi, in the Midwest in Ohio, in Columbus, Ohio, to Ohio State, and here in Georgia as well. And, we see people with disabilities coming to this space, not because they have true medical emergencies, but rather because the caregivers, for whatever reason, don't have the capacity to take care of their loved one. It's tough to see. We often don't know what to do with that person. We end up admitting them and it costing the hospital tens, if not more dollars. So there's a cost issue at play here. There's an education issue with amongst healthcare staff and understanding how to work with people with disabilities. And we need to find a way to bring this all together and kind of provide space and give these individuals autonomy so that they really can live their life with integrity.
Absolutely. Thank you, Jose. So we are happy to explain and go into more detail about some of the topics that we discussed today. We realize that it is a lot to digest in the time that we have together. So we wanted to give sufficient time for questions. And we'll, of course, take a look at the chat in just a second as well. If you are curious and want to know more about Unlock Georgia, you are welcome to sign up to be a subscriber at unlockgeorgia.com. We also had, if you're curious about the rate study that we discussed on our Facebook and actually on our website, you can watch our last live stream, which was at the beginning of August. We have a Facebook page at Unlock Georgia. We continue to do trainings. We just finished some training. We're doing a summer advocacy push with our funder, GCDD, the Georgia Council on Developmental Disabilities. And Jose and I are planning to do trainings right before the legislative session on sort of how to navigate our state capitol and advocate during that January through March period. And let's take a look in the chat here. My senior community, Beverly says, we have caregivers who are elderly while caring for a family member with a disability. It's heart-wrenching when the caregiver gets sick or needs caregiving themselves. Right, I absolutely agree with that, Beverly, and am very tuned in to our caregivers who are aging and are supporting individuals with developmental disabilities. For most of us, we feel that we cannot die, right? And that's a difficult thing to say, but it is certainly true in many cases and situations.
I also like Beverly's comment because it gives kind of a new spin for many people in regards to disability. No matter where you're at in your spectrum of life, we don't know where we're going to be 5, 10, 15, 20 years from now, right? So even though you may not feel like the fight is personal to you right now in regards to caregivers, you don't know if you'll be relying on one in the future. So I just want to throw that out there.
Absolutely. Dion says, do you ever get the opportunity to address the special costly needs of rare disease patients and families?
I feel like I need more context to that, but let me say this. When we talk about disability, we're talking about a marginalized population that often has more comorbidities than any other population. So by default, when we talk about healthcare, we're really advocating for all those special populations. But Dion, if there's something you're thinking about in mind, let us know, and I would love to expand.
And I think something that often we don't speak about, or I'm hoping that we will be able to have those conversations. I think they're coming, is individuals who have intellectual and developmental disabilities, and also, as Jose said, other comorbidities, including mental health conditions as well. And so in Georgia, we have, and Jose can talk about this because these are the homes that you run. We have crisis respite homes and crisis homes for individuals that are really struggling. And Jose, I don't want to put you on the spot, but it's such a vital service that we have here that you guys provide. So
Right. So
can you
if
talk a little about that? Yeah.
absolutely. So if somebody with a disability or a behavior issue related to disability comes into the emergency room and we don't know where to send them, we have these crisis homes where they'll spend 2 weeks. We'll link them up with a complete healthcare team, a nurse, a behavioral specialist, a DSP, and we'll include their family in this training for about 2 weeks so that we can kind of figure out what's going on from a behavior standpoint. We'll also include a psychiatrist to make sure if medications are required, those are also in line with treatment. But it's a really unique program that's here in Georgia. You might see it in other spaces called something differently, but here we call them crisis homes. Now, whether or not we have enough of those is an entirely different question and issue.
So Linda's is talking about Florida, and Florida's wait list is about 22,500. Oh my goodness, I think that is probably one of the larger ones, along with Texas. Although I did hear recently that Florida appropriated 1,200 new waivers, which is a huge amount of waivers. So I hear you, our neighbors and friends in Florida. And Naomi, I think someone had their hand raised.
Dion, do you want to come in and elaborate on your question, or was it answered?
No, I was just going to give Jose some context. So on a national level, there is a legislation that is currently making its way around committee around the special needs of off-label drugs for rare disease patients. And since we know that Congress doesn't work like it's supposed to work and it takes its time, I was wondering, on a state level, do you ever get a chance to bring up during your meetings the special needs that rare disease patients have as far as off-label drug and approval? And here in Missouri, Medicaid is a lot, it's complicated. And so especially for rare disease patients who were children that are aging out into adult medicine that kind of get lost in the system and they don't know exactly where to go, and they don't have the protection and the community that pediatric medicine provides. Sometimes they don't know that they are eligible for Medicaid. They don't know how to apply for it. And it was up until recently, you had to be pregnant in Missouri as an adult before you would get Medicaid. Now it's a little bit different, but they don't automatically approve everyone.
Yeah, so many points to hit on there. Answering your first question, I personally don't just limit my healthcare advocacy to the IDD community, but for the most part, that's where my focus has been, just because of my function here at In Community as the Chief Operating Officer. But in different spaces, I'm able to advocate for that at a state level. And I think that's really important because there's an education piece, which is probably the biggest piece. Understanding medicine at the government and state level is complex, right? And the people who often advocate for us are people without MDs or PharmD degrees. So I think it's really important that when we fight this fight, when you fight your fight in advocacy in Missouri, you get more people involved than, just families and advocates, which are enough and a lot, but make sure you get your healthcare professionals in that fight. Make sure you get state legislators who have a connection to the community or the rare disease or medications that are most important to you. That's really the idea behind Unlock, is creating a broad-based coalition of different people from different spaces who all believe in the same thing. And when you create something that big, when you create something with a diversity of people and thought, it becomes more powerful because now you're approaching it from different levels, and most people have a different network pattern. And at some point, you're going to hit the right bell and you're going to get to where you need to go. I'm not saying it's going to be fast. A lot of this change is incremental. So we're going to have to practice patience. But, if there was a surefire way to get all this done tomorrow, I promise I would tell you.
Thank you. I'll be reaching out to you.
All right. Thank you.
Yeah, I don't know if this is helpful at all, but in our scope of Unlock in our project, it is specifically for home and community-based services. And so we are a little bit limited. I love the advice that Jose just gave. I think it is very useful and practical, and I hope it inspires further thought and action. Our scope and our focus is our home and community-based services, and anything related to them, such as the Medicaid waivers we talked about, wages for DSPs, direct support professionals, more investment in that system. Beverly says we also have residents with disabilities. This is a really important point, Beverly, that have been moved into this independent living community. That's interesting. So it's a dedicated community for individuals with disabilities, I'm assuming, but let me know if I'm right or not. The family members assume there would be public agencies to support them. Often it's not enough to keep them safe and fed. And I think you bring up a great point. As our individuals become adults, the challenge that we have with what happens when caregivers pass, or what happens when they live in these independent communities, is what is the level of support that is adequate. We want them to be more than safe and fed, right? Those are the basic needs. We want them also to be connected to their community. And it's important that those basic needs be met first, of course.
This is not, this is an over 55 community.
Oh, gotcha. Okay.
Yeah, so it is a community where you have some people who are still going to work, but they will leave people here assuming that someone within the community will help them and that there will be enough support or activities to keep them. And a lot of times it just doesn't happen.
Okay, I hear you. Okay, so it's a little bit of a different situation. So people are assuming that there will be supports there that may or may not be there. Yes. Okay.
Or
Thank
they
you for
or they
clarifying.
can get an agency or they can get a home care agency to come out and help them. And home care agencies, are only 3 to 4 hours. They're not 24 hours.
Okay, so those folks that you're describing may need more support than in that particular community.
Absolutely.
Yeah. Okay, thank you.
Rosie, I see your hand up.
I just wanted to say I appreciate you sharing your story, because I work with this in Wisconsin as I'm a participant because I'm disabled because I've been amputated. So I'm a participant, but I also am involved very much on the advisory boards and very much involved in sharing the knowledge that I've collected across the state and the country, to help others. Like I'm doing a presentation on what are those Medicaid waivers and why are they important, and why, and help people understand the confusion of it. That's one of the presentations I'm doing in October. But I just think that there's not enough people that understand it and understand why this is important. And Jose, I believe you said it right on the head when you talked about the wages. We are a little better here in Wisconsin. It's at $17.98 as the highest that you can pay someone, but there's still people making $20 an hour at Burger King. So, it's not the same. One of the things we did create here is we have now a free training session offered by the UW, one of the UW colleges, that is an online course that caregivers can take and be trained. And after they're trained, they will get a $500 bonus. So not, even if they're already a caregiver and they're taking the training, they'll get the bonus. Or if they take the training and then become a caregiver, they'll get a $500 bonus. And so that has been an incentive to increase the, and also develop a place where we are now collecting names and information about caregivers that have been trained. So that is one of the things that we've spent a long time working through this year. So
That
That's
is
awesome.
really, yeah, that's helpful to know, Rosie. So you self-direct your services. You participant direct your services.
yes.
Okay. Excellent.
Yeah, thank you for sharing your experience, Rosie. And I think you bring up another excellent point, which is it's not enough to create equitable wages for DSPs, but also understand that from the retention side, you need to create a career pathway so that they stay in these spaces or grow within the organization themselves. And that career ladder approach is important to all of us, not just in the DSP space, but without that, we're setting ourselves up for failure. And I think that's something we're looking to advocate for as well.
And I guess I feel really strongly about that. I felt strongly about it as an educator, that you can't just say, well, you're going to be trained in 1 hour or 2 hours or a couple hours, and that's what they do. And I mean, I have a granddaughter who works with a developmentally disabled young lady, and she had never hired a woman, and now she's hiring, and she's, this woman doesn't speak. So she uses her phone once in a while, but usually it's more like you need to know what she wants when she wants it, and those kind of things. And there too, she has 2 hours in the morning, and then she has from 4 to 11 in the evening. But during the day, so then she prepares like her food and things for during the day so that she doesn't starve during the day. But she's a college student who does this as a part-time, and so if somebody doesn't show up to take care of her in the evening, that means she sleeps in her wheelchair. And so, I mean, my granddaughter has literally driven 2.5 hours one way to make sure that she doesn't sleep in her wheelchair. But that's not every person who has a job attitude, but because I think, my granddaughter knows how important it is to be able to be productive and survive with a disability. She's learned a lot from me and from my involvement, that she couldn't, when she heard that the person didn't show up for work, she said I could not do anything. I had to get in my car and drive and take care of her. And in Wisconsin, that meant it was in the winter in a snowstorm. She drove 2.5 hours one way, and then she came and stayed at my house overnight, which was an hour away, and then drove back to school the next morning for
I
class.
often get asked, Jose, how can I advocate? I might not be able to go to the state capitol. I might not have the connection I want with my state representative. And although we can help you find who that is and make sure that happens as well. But let me double down, Rosie, on something really important that you're doing for us right now, which is storytelling, right? In talking about those healthcare heroes and talking about the disparities when it comes to people with disability and what that looks like. Because I think part of this advocacy issue as well is just that people don't always know there's a problem. There's some pieces of medicine that are controversial, addiction medicine, maybe family planning or abortion care. But when it comes to Down syndrome, nobody's against somebody with Down syndrome, right? Or Fragile X syndrome or blah, blah, blah. But people also assume because they're non-controversial pieces of healthcare that the state or federal government has afforded for these issues and the healthcare related to. And so when we share stories like that, it kind of raises up the special attention that such a messaging deserves, and that advocacy is still required in these spaces. I really appreciate you sharing that story. What a healthcare hero.
It's an amazing story.
Well, and I just think that that's part of the problem, is that they don't understand the needs, and they also don't understand it's not just the work that they do is not the same as the work that somebody is going to do in a fast food, and there's an attachment that develops. My granddaughter said to me when she was going off to college, because I convinced her to do this, to take care of this young lady for the summer last year, and when she went off to school, she said, Grandma, I got so much more than just a wage out of this. I gained so much confidence doing this. I'm now a much more confident person because of the work that I've done this last summer. And she said, because I know I have a whole lot more ability than I thought I had.
Wow.
To function and to take care of people and to care about people. And so, I think sometimes those kind of stories aren't told, and we don't hear those stories. We don't hear about the success of people and how important it is to your well-being, even as a provider, as the person who's providing the care, how important that well-being is of being able to help someone. And you're also very true when you say, Rita, about, when I go to conferences now, you see people in their 90s taking care of people in their 70s. And that's a really hard thing to see, because you're thinking tomorrow this person in the 90s could be gone, and what is this person in the 70s going to be doing?
Yes.
And I think that's a whole gap that we're not even addressing. We're not even thinking about how we're going to, when these people are caregiving long beyond the age that we would have expected them to have to caregive.
Absolutely. Thank you so much, Rosie. Naomi, you've got a couple of really deep, in-depth questions in the chat. I'd love to get to those, if that's okay with folks. How can healthcare systems engage the IDD community, and why is that important? Jose, did you want to chime in first?
Sure.
Yes, and I'll be thinking about it.
Absolutely. So I think this is a really important point, Naomi. And I say this because I don't know that, at least in Georgia or in the South, where I've seen IDD providers and individuals that play with other healthcare systems, that they're always on the same page. They always have the knowledge and fortitude to understand the population and the complexity of the disease and or not disease state that they might be in. Health systems are catching up. That's really the truth of the fact with what it means to serve somebody with disability, let alone the disability part. There's often behaviors behind that. There's often nonverbal social cues involved. It can get really complex really quickly. And so our hope as we continue on with advocacy efforts is that we are able to engage other healthcare systems at every level to inspire and encourage this knowledge so that they can provide quality healthcare at every single level. And in fact, just let them know there's a problem. Interestingly enough, In-Community has an arts program. And somebody might think, why does a DD provider have an arts program? Well, part of it is, we went to museums with our individuals and they couldn't get in the door. There's accessibility issues. The seats weren't big enough. There wasn't wheelchair access. It was too bright. There was flashing lights. They had vision impairment, and so they couldn't see things in the way that somebody or the curator at the museum wanted to see them. And so it took us to build a program like that to create accessibility in Atlanta and in certain places in Georgia. And I thought that was a really cool attempt on our part to realize that healthcare isn't just about a doctor or a nurse or an individual and a DSP, but rather it takes a whole community to engage in that process, because quality of life means just as much as sick care. Actually, it means more, right? I want to make sure that people experience a quality of life outside of when they may be sick or not, to thrive. Rita, thoughts?
Yes, absolutely. It's important to talk with individuals with developmental disabilities and their family members, and to partner with them. As Naomi in her second question, I believe there is an unconscious bias Part of that may be a little bit of discomfort, perhaps, and this is my opinion only, and things that I've experienced as a parent. If you were to ask my sons, they might say something different, right? But oftentimes when I take my son to the doctor, my younger son, the doctor will not talk to him, he will talk to me. And so I think part of that is, okay, can we get over the discomfort? And so to maximize my son's independence, sometimes I send him with a direct support professional so that it's not always mom there, right? And I want people to get more comfortable with having a conversation with him, because he can understand most everything you might tell him. It might be slower processing, etc. But it's talking to that individual and first. And maybe if mom or caregiver or support staff needs to be there to help translate or to support, great. But really focusing on that individual and empowering them to advocate for their own health care too. And it will take some time to do that. But I think our folks with IDD can provide just so much rich information and gifts if we only take a little bit more time to get to know them, right? And I know our time is limited. We have 1 more minute, Jose. Do you want to say?
No, I just echo everything Rita said. And I think one of the key points there is we need to engage and talk with our people with IDD, right? They are the center stone of this conversation and their voice needs to be heard. I know we have another question, or I'm trying to keep up with the chat.
Yeah, the question was about expanding. Do you see if this would be expanding across the US? And I'm thinking she's thinking your program.
Yeah, so we would love for Unlock to expand across the US. And I think we're really doing something novel and different. There's a few states, I'm a part of a national organization called ANCOR. And so I follow a lot of these trends, especially when it comes to advocacy. There's a few states that have something similar to us, but I think thinking about the time and the speed that we were able to get this off the ground is really amazing, and how quickly we built the steering committee and soon enough membership piece. But it is our hope that this expands. We don't own Unlock in that way. This is very much an everybody advocacy state, especially when it comes to the DD population.
This has been a fantastic conversation. I hope we've gotten to most of the questions and comments. I just appreciate all you, everyone that's listening, all you folks that are watching from all across the country. It's been a pleasure to be with you this afternoon, and our contact information is here if you want to reach out to us. And with that, I will send it back to Naomi. How did I do, Naomi?
You all did wonderful. So glad that you're here, Jose and Rita, giving you a round of applause. Thank you so much. For those that have joined us, thank you for being here. And I know this was a bit different. The last couple of community of practices that we've had have not been our typical coming from researchers or from healthcare systems, but actually coming from the community. And that's what we're wanting to do, to show how do we actually engage and hear from both sides. So you have Jose, I really want to say Dr. Delgado, because that's just how I've been trained, and Rita's information and being able to connect with them. We have been recording and we'll share that out with you all. If you have not joined if you have not joined, subscribe to our YouTube channel, and Naomi is being tech challenged right now. Please do so. I have it up on the screen there. And without further ado, have a happy, fun, safe last Friday in August, and we will see you the last Friday in September. Take care.
Thanks
Thank
all.
you.
Thank you.
Thank you, all of you.